Welcome. I hope you're having a great day. In the U.S., depression estimates range from 5 to 10%, but can extend as high as 40% depending on the population seen in primary care. Only about half of depressed persons received adequate treatment in spite of quality, evidence-based therapies. The presence of depression significantly impacts the prevalence, cost, and outcomes of a number of common comorbidities, particularly diabetes. Depression is the leading risk factor for suicide, which has risen 25% in 15 years. While screening, diagnosing, and managing depression in primary care settings may seem overwhelming for some primary care providers, there are few other conditions as worthy of significant time and attention. The objective of this presentation is to review current evidence for screening, diagnosis, treatment, and practice improvement of depression. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, or the DSM-5, has this list of depressive disorders. We will be addressing major depression, depressive disorder, and a little bit about minor depression in this lecture. Which patients are at especially high risk for depression? The pathophysiological cause for depression is unknown, and there are no useful serum markers of depression. The primary care provider may use the following risk factors for depression when determining when to screen: alcohol dependence, comorbid chronic medical conditions, female sex, personal or family history of depression, recent childbirth, recent stressful events, or as I like to call it, situational depression. Should primary care providers screen for depression? Well, depression screening instruments can accurately identify patients at risk for depression. The 2016 United States Preventative Services Task Force guideline recommends screening all adults, including pregnant and postpartum women, as well as older adults, for depression. Primary care providers should consider screening patients with identified risk factors or who present with unexplained somatic symptoms, chronic pain, anxiety, substance misuse, or non-response to effective treatments for medical conditions. The optimum interval for rescreening is unknown. What methods should primary care providers use to screen for depression? A positive response to the 2-item self-administered patient health questionnaire, or the PHQ-2, instrument has a sensitivity of 96% and a specificity of 57%, which is similar to longer instruments. The PHQ-2 can be used in the older population and may have similar effectiveness with greater brevity and ease of use than other instruments. Patients with a positive response to one or both questions should have a more complete assessment to determine whether they meet the criteria for depression disorders according to the DSM-5. The Patient Health Questionnaire 9 is both a diagnostic and severity rating instrument and may be completed by the patient and used as a follow-up to a positive PHQ-2. The Edinburgh Postnatal Depression Scale was developed to assist postpartum depression. Elderly are especially prone to depression, and the Geriatric Depression Scale was created for this population. What are the diagnostic criteria for major depression? Major depression is diagnosed when 5 or more DSM-5 symptoms occur in the same 2 weeks with a change from previous functioning. One symptom must include one of the first two in red, depressed mood and anhedonia. The core symptoms of DSM-5 major depression describe a specific depression syndrome and do not necessarily represent a severity index. Only a clinical interview or use of a validated depression screening tool can determine the severity of a depressive episode. The symptoms that are listed here are also continued on the next slide. The continuum of clinical depression ranges in severity from subsyndromal symptoms to the syndromes of minor depression and major depression. The 13 criteria for the DSM-5 include depressed mood most of the day, nearly every day, as self-reported or observed by others. Diminished interest or pleasure in all or almost all activities most of the day, nearly every day. Significant weight loss when not dieting or weight gain, or decrease or increase in appetite nearly every day. Insomnia or hypersomnia nearly every day. Psychomotor agitation or retardation nearly every day. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt nearly every day. Diminished ability to think or concentrate nearly every day. Recurrent thoughts of death. Recurrent suicidal ideation without a specific plan. The symptoms cause clinically significant distress or impairment in social, occupational, or other areas of functioning. The symptoms are not attributable to the direct physiologic effects of a substance, like a drug or medication, or a general medical condition like hypothyroidism. The occurrence of the major depressive disorder is not better explained by a schizoaffective disorder, schizophrenia, or other specified or unspecified schizophrenia spectrum, or other psychotic disorders. And there's never been a manic or hypomanic episode. The continuum of clinical depression ranges in severity from subsyndromal symptoms to the syndromes of minor depression and major depression. Unipolar minor depression is characterized by 2 to 4 depressive symptoms that are present during the same 2-week period, along with distress or psychosocial impairment. Compared with major depression, minor depression tends to have shorter episodes, less comorbidity, less psychosocial and physical impairment, and fewer recurrences. These criteria for minor depression are similar to the criteria that are used in the American Psychiatric Association Diagnostic and Statistical Manual of Mental Disorders, 5th edition, and it fits other specified depressive disorder, depressive episode with insufficient symptoms, and I think that's about it on that. And then most minor depressive episodes are treated by internists, family physicians, and other primary care clinicians, sometimes in conjunction with psychotherapists. However, for moderate to severe episodes that are unresponsive to multiple 2 or 3 treatment trials, you probably should refer the patient to a psychiatrist in addition, and then referral is definitely indicated for suicidal patients. How can primary care providers determine the severity of depression? So, assessment of the depressive symptom severity helps guide treatment. Mild depression may not require medication, only psychotherapy or behavioral therapy. Mild to moderate depression responds equally well to medication or psychotherapy. And patients with severe major depressive disorder benefit more from medication alone or combined with psychotherapy than from psychotherapy alone. The PHQ-9 is easily scored to quantify the severity of depression. Like suicidality, severe functional impairment such as inability to provide self-care may suggest the need for a psychiatric consultation or even a hospitalization. Here are the total 9 criteria in the PHQ-9. Over the last 2 weeks, how often have you been bothered by any of the following problems? These are rated on a Likert scale of 0 meaning not at all, 1 several days, 2 more than 1/2 the days, and 3 nearly every day. The first 9 items reflect the 9 DSM-4 criteria. Item 10 assesses functional impairment. Like symptom severity, severe functional impairment may suggest the need for hospitalization and psychiatric consultation. So items 1 through 9 are summed to yield a total score ranging from 0 to 27. You have a copy of the PHQ-9 and its scoring on Blackboard. How should primary care providers assess a depressed patient's risk for self-harm, including suicide? Each year, over 30,000 U.S. citizens die by suicide. Between 1999 and 2014, the age-adjusted suicide rate in the U.S. increased by 24%. This increase was most notable between 2006 and 2014. Mental health conditions and addictive disorders such as alcohol use disorders are the most powerful risk factors for suicide in all age groups, present in more than 90% of all suicides. In a patient with major depression, previous suicide attempts are the best predictor of completed suicide. Interestingly, most patients who die by suicide have seen a primary care provider in the recent preceding months. So, primary care providers should assess acute risk for suicide at each visit for depression. Then over 50% of men who kill themselves do it with the use of a firearm. So asking about and reducing access to lethal means, especially firearms, can reduce this risk. A psychiatrist should be consulted for any uncertainty regarding suicidal risk. When should primary care providers consult a mental health professional for help diagnosing depression or a related mood disorder? Although many mood disorders can be successfully managed by the primary care provider, psychiatric consultation should be considered for diagnostic uncertainty, psychiatric comorbid conditions, significant risk for suicide, or suboptimal response to treatment. The clinical bottom line: screening. Primary care providers should screen for depression as the first step in a systematic evaluation of mood disorder in all adults. Adults who are postpartum, have personal or family history of depression, or have comorbid medical illnesses are at increased risk. The PHQ-2 is a widely used and efficient screening tool for depression. The clinical bottom line for diagnosis. The DSM-5 criteria are the standard for diagnosing major depression. The risk for suicide and comorbid mental and physical illness should be assessed in each patient. If primary care providers are uncertain about the diagnosis, risk for suicide, or need for hospitalization, psychiatric consultation should be considered.